I'd like to acknowledge the local custodians of the land in which we meet today and honour elders past, present and emerging. I'm Mel Wilkinson from the PHN. Welcome today to the Practice Incentive Program General Practitioner Aged Care Access Incentive. Just a little bit of housekeeping. Please remain on mute. If you have any questions, we encourage you to pop them into the chat box and we'll get to those at the end of the session. If there's any that are taken on notice or if there's any that we don't get time to get to, we will endeavour to follow those up via email. Today is being recorded and as usual will be available in our education library on our website. And there will be a survey at the end and we do encourage you to complete the survey. This is how we get our information for further events and to plan for the upcoming year. Presenters today with me online, I've got the lovely Heidi Avery. Welcome Heidi, and Jacqueline Hewitt, and they're both from the PHN, so welcome today. Okay, so I'll hand over to you now, Heidi, and we'll get started.
Great, thanks Mel. Okay, welcome everyone. Today, our learning outcomes we're going to look at will be the Practice Incentive Program for General Practitioner Aged Care Access Incentive, what it means for GPs, who is eligible, payments and requirements, eligible MBS item numbers. We're then going to look at the practice incentive payment for Inreach residential aged care and disability support worker COVID-19 vaccination. How will this work? How is the payment provided? Then I'll hand over to Jack Hewitt, our aged care program manager, who will talk about the shortages and challenges working in residential aged care facilities and innovative models of care and care coordination roles within the residential aged care facilities. So the Practice Incentive Program encourages general practices to continue providing quality care, enhance capacity and improve access to health outcomes for patients. To be eligible for the PIP General Practitioner Aged Care Access Incentive payments, GPs must be registered in the PIP at an approved PIP practice, use a Medicare provider number linked to the PIP practice when claiming MBS services in a residential aged care facility, provide eligible MBS services to residents in the aged care facility, and reach the qualifying service level by providing the required number of MBS services in a facility in a financial year. I will talk about what the qualifying service level is a little bit further on in the presentation. So as of the 1st of July, GPs offering aged care services will be entitled to receive a maximum yearly payment of $10,000 through the introduction of additional qualifying service levels and incentive payments. The funding is part of the federal government's response to the Royal Commission into Aged Care Quality and Safety. It is designed to help support the health of the 244,000 Australians living in residential aged care facilities by increasing face-to-face contact with the GP. Capped at $10,000, GPs will receive service incentive payments based on the number of eligible items they deliver to a patient in a financial year. So the incentive payments are based on GPs providing the required number of eligible MBS services. To receive the PIP incentive is made up of 4 payment tiers. So to receive the Tier 1 payment of $2,000, GPs must provide at least 60 eligible MBS services. Tier 1B payment of an additional $2,500, the GP must provide at least 100 eligible MBS services. Tier 2 payment is an additional $2,500 and the GP must provide at least 140 eligible services. And Tier 2B payment of an additional $3,000, the GP must provide at least 180 eligible MBS services. So eligible GPs can get 4 payments totaling $10,000 for the financial year. Payments are automatically paid, I must add into that as well that this is in addition to the consultation fees. So payments are automatically paid to GPs who reach the qualifying service levels by providing the required number of eligible MBS services in residential aged care facilities. The services count towards the QSLs when GPs claim the MBS services provided in the aged care facility using a Medicare provider number that's linked to the PIP practice. Where a QSL is met after the processing of claims in May and June, an adjustment payment is made in August for the previous financial year. This PIP is a revised version of the old aged care PIP, but the old one was only 2 tiers with an incentive of only $5,000, where this one has now doubled. For eligible GPs working in a MMM 3 to 7 area, they will still receive their Workforce Incentive Program doctor stream payments, as well as the PIP aged care incentive payment. So you do not have to apply for this incentive if your practice is already participating in the Practice Incentive Program. The PIP GP Aged Care Access Incentive Payment is made once a GP has claimed the required number of MBS items. These are service incentive payments, so the payment is made quarterly and paid into the GP's nominated bank account. The payments are accumulated, meaning if a GP delivers 100 MBS services to patients in residential aged care facilities in 2021-22, they will receive a total payment of $4,500. So $2,000 for delivering the 60 services under Tier 1, and then they'll receive $2,500 for delivering 100 services classed as Tier 1B. So that's a bit of an example of the breakdown. So this is effective for services provided by GPs from the 1st of July, and first payments are expected in the November 21 quarter. So eligible MBS services are those provided to residents in Commonwealth-funded residential aged care facilities and multi-purpose services. So multi-purpose services are integrated health and aged care services that provide flexible and sustainable service options for rural and remote communities. So here is a breakdown of services and item numbers that count towards the qualifying service levels. So Services Australia have indicated that they may update this list to include or remove MBS items, so just keep an eye out for any updates that may get released. So as you can see, there are professional attendance items, after hours, residential medication reviews, and chronic disease management. So the next topic I'm going to briefly talk about today is the new practice incentive payment for Inreach residential aged care and disability support worker COVID-19 vaccination. So an expression of interest went out to practices a few weeks ago, and for those practices that showed interest, this will help you understand what this means for you. So the focus of the additional payment is to give residential aged care and disability support workers every opportunity to access a COVID vaccine before the requirement to be vaccinated becomes mandatory for residential aged care workers on the 17th of September this year. So it will be a condition of employment to have received a minimum first dose of the COVID vaccine for all people who work in the residential aged care facility. Primary care vaccination providers are one of the number of available vaccine access points, and they have an important role in ensuring that aged care and disability support workers are vaccinated. To support primary care vaccination providers to conduct Inreach COVID-19 vaccination clinics, additional funding will be available to primary care vaccination providers who administer an Inreach clinic in residential aged care or disability care setting from the 29th of April this year until the 31st of October this year. So these payments are provided to vaccination providers in addition to the per patient fees payable in line with existing funding arrangements for COVID vaccine assessment items and any PIPs or any equivalent for Commonwealth vaccine clinics. So the funding includes a $1,000 payment once the minimum threshold of 50 unvaccinated residential aged care or disability support workers have been provided a vaccination in an Inreach clinic. So $20 for every dose provided to an unvaccinated worker thereafter, with a maximum payment of $40 per worker for 2 doses. So additional funding is only available where an Inreach service is conducted and not where aged care or disability support workers attend a general practice, a Commonwealth vaccination clinic or an Aboriginal and Torres Strait Islander community controlled health service. They are only for in the workplace. So what if you don't meet the threshold? If you don't administer the minimum of 50 COVID vaccination doses as part of an Inreach clinic between the 29th of April and the 31st of October, then no additional payment will be available. You can, however, backdate to the 29th of April, where sufficient evidence of Inreach vaccination clinics can be provided to support the claim. And payments can be claimed up until the 31st of October 2021. So can you get additional payment for aged care resident vaccinations? The bottom line is no, you won't get an additional payment to vaccinate residents. Although it's encouraged to vaccinate residents during the Inreach clinics, you will not accrue any additional incentive. The focus of the additional payments is to give the workers every opportunity to access COVID vaccine before the 17th of September. The relevant MBS COVID vaccine items or equivalent Commonwealth vaccination clinic payments can still be claimed. So priority consideration may be given to practices that have an existing relationship with a residential aged care facility. If you have already made plans to vaccinate any workers, please email the PHN at vaccine@thephn.com.au, because this is important to let us know that as we want to ensure that workers are vaccinated and are able to continue to work past this date. We want to keep as many of our workers at work as possible. Disability workforce Inreach clinics may be coordinated directly between disability support providers and primary care providers. In this case, it is not a requirement for the PHN to coordinate and report. So to be eligible to receive the payments, primary care providers must report the relevant details for each facility visited through the COVID vaccination administrative system. So functionality will be available in CVAS from tomorrow. These reports can be submitted retrospectively and backdated from the 29th of April. So for Commonwealth vaccination clinics, payments will be made on receipt of an invoice that includes the number of doses administered and residential aged care and disability support workers as part of an Inreach clinic. Providers will need to ensure accurate information on the number of doses provided to the workers is recorded in CVAS and retain all relevant records relating to the administration of the vaccine. Payments will be made based on the number of doses provided by the primary care vaccination provider as part of an Inreach clinic. All other payments for vaccination services remain the same. You will still be able to claim the suitability assessment item numbers for eligible patients along with the flag fall item. Primary care vaccination providers are responsible for ensuring an appropriate model of care and clinical governance for vaccine delivery, and that includes determining the patient's clinical suitability, to receive the COVID-19 vaccine on this date, including identification of any precautions or contraindications, as well as vaccination history, which should include checking the Australian Immunisation Register. Obtain and or confirming informed consent, appropriate post-vaccination observation periods, and clinical escalation processes for any vaccine-related adverse events, including reporting to the appropriate organisation where required. All reporting requirements are met, such as uploading administration data into AIR and maintaining appropriate medical records per vaccination assessment, administration including ensuring Commonwealth vaccination clinics provide data through their app. Maintenance of vaccine cold chain integrity during transport and at the site of administration to ensure vaccine potency. That the Inreach clinic set up has adequate infrastructure for clinical safety to be maintained. So vaccination providers should also maximise the available doses to avoid wastage. So plan to utilise all the doses within the vial where possible. Bring all required vaccine administration consumables and equipment as required. Plan for the individuals who receive the vaccination to have access to a second dose. And that's about it for the Inreach Clinic. So now I'm going to hand over to Jack Hewitt, our aged care program manager, to speak more directly about supporting the aged care facilities. So welcome again, Jack, and I will hand over to you now. Thanks.
Thanks so much, Heidi, and thanks for having me, everybody. Good afternoon. My role in the PHN is a relatively new one, although I've been in aged care for 43 years, one way or another. I wanted to briefly just talk about the challenges for GPs in working in aged care facilities. I know they're vast. We acknowledge that. The Royal Commission acknowledged that. And there's a lot of things being put in place to try and mitigate those challenges. I want to say that from the federal government, the support for primary care into aged care ongoing from now is unprecedented and very, very welcome. We acknowledge some of the challenges with GP workloads going into aged care facilities and also welcome the incentive payments to become a true aged care friendly practice. It's fabulous and we need it. We acknowledge that the system is somewhat stressed, and I say that a little tongue in cheek, and even more so now with the COVID outbreaks that we're having. So I just want to encourage every practice that is in aged care or thinking about being in aged care to please remain in the system and work with us to fix the system. We need good GPs and practices to help make sure that our elderly parents really and if you're like me, on the verge of heading there, we need us to get this right, and good GP support is vital. So with that, I just wanted just briefly to move on to the next slide to talk about some of the different models of care that are being used in aged care at the moment, and obviously the first one is telehealth, and by telehealth I mean video conferencing and consults between the GPs and the resident at the aged care facility. The PHN is supporting pilot programs at the moment for both routine and urgent consults in aged care, and supporting the aged care facilities with education and hardware to make sure that that's a really good connection and a good experience for the GP, and there's a big set of rules to follow. So I really see that as becoming more everyday kind of way of managing aged care residents. Not, of course, it shouldn't replace face-to-face as appropriate. The other models that are out there that also work very well and get really good feedback from both GPs and the nurse practitioners is the GP nurse practitioner shared care model, where the nurse practitioner is employed in the aged care facility. There aren't many of them, but there will be programs to try and increase those moving into the future. So I do. It is an excellent model, and it's got some great outcomes. And there's a paper awaiting publishing that talks about that. There's a GP aged care practice liaison nurse models, and there's a few of those around where the GP practice actually employs the aged care specialist nurse themselves, who coordinates and triages all of the calls and the workload for the GP that before they visit, and make sure that it's a very streamlined consultations, both face-to-face and telehealth. And then there's the care coordination model of care that's been explored even locally at some of our aged care facilities as a result of some of the recommendations from the Royal Commission, where they employ a care coordination nurse specifically to work with GPs, other visiting specialists and allied health to coordinate the care of residents in their facility. So they're four that we know of, but part of today is just a bit of a reach out to ask GPs and facilities if they've heard of other good innovative models that they'd like the PHN to explore. Please let us know. Drop us a line and at the PHN, and we will definitely look at that. We've got a remit at the moment for a lot of aged care work, and we want to support the GPs in their often difficult work in managing their patients that live in aged care facilities. So that's all from me. I'm happy to answer any questions, as I'm sure Heidi is too, and we'll hand it over to you.
Great, thanks, Jacqueline. If anyone has any questions, it's the time for you to pop them into the box or into the questions box or the chat box. So I'll just give you a couple of minutes to do that, and I'll check that again in a minute. And just a reminder that we are being recorded and it will be available on the Education Library in the next 24 hours. And to please complete the survey at the end of the session so that we can have that information to plan and implement some more education based on that feedback. So thank you both for today. There's a lot of content covered, and so well so that there doesn't seem to be any questions coming in so far. So, okay, I've just had one come in. What item numbers for telehealth are for Rcfs?
I'm in the process of putting some resources together on all item numbers that can be claimed in a residential aged care facility.
Yep.
We've just been inundated with COVID issues at the moment, so if you can just bear with me, I'm all but finished it. Once I get that done, that will go out to all practices. So
fantastic, thanks so much, Heidi.
At the moment, sorry.
Fair enough. It's been a busy time. And there's another one there. Just could you bill 10660 on a separate date to the COVID items?
No, they have to be claimed together. Yeah.
Okay. Our practice has just run a specific ACF worker clinic, as the ACF nurses were not confident administering the vaccine. Are we still eligible?
Can you say that one again? Sorry.
Yep.
Annabelle.
Our
sorry.
practice is just. We're going to say something, Jack? No? No? Our practice has just run a specific ACF worker clinic, as the ACF nurses were not confident administering the vaccine. Are we still eligible?
So as for which, if it's for the PIP program for the aged care access incentive, so it's paid to the GP. So as long as the GP is performing the services and attending the facility, yes, the GP will get the payment for it.
Great.
Sorry, I'm not sure if that's what the question was referring to.
Can I just clarify, was that for residents that they gave it to or for workers?
Okay, so we'll just get the person, I think it was, and I'll give you the name
Or
just
if
to
it's for
add a
the
little bit more detail there.
If it's for the Inreach PIP payment, as long as the GP is there and the workers are getting vaccinated in the facility, well, then the GP will get the payment.
Okay, yep, Anne's just written yes for the PIP. Next question. I work in a practice in an MM1 area, so we don't have PIP program. This means I can't use the incentive program for the aged care residents, is that right? Or I can use the incentive program for this aged care residents in an MM1.
You can still be accredited in an MMM1 area. So as long as the practice is accredited, they will automatically get the PIP payment. They don't have to do anything extra besides do the services. Yeah.
Great. And one from Vicky Phillips. Hi team, can you tell me if the threshold of 50 for the Inreach clinic is across Rcfs, or does it have to be 50 within one facility?
Across.
Okay,
it is across.
Great.
It's cumulative, and I think it also applies to, and Heidi, correct me if I'm wrong, also applies to any cumulative disability. So it's across both, across all, if that makes sense.
Yeah.
Okay. Another question, can you backdate billing for a 10660?
Yes. I just can't remember backdate until what date. I'd have to go back and look it up. Sorry,
That's
can't.
okay. We'll take that one on
off
notice. Yeah, we'll take that one on notice and send an email out on that one.
It does say it on the fact sheet, but I'm just not sure of the actual date. Sorry.
Okay, no, we'll take that one on notice. Has the age restrictions of over 50 been taken care of? If so, from when?
There's no age restriction on those item numbers anymore for the in-depth consultations. Once again, everything's got different dates on it, and I don't want to say it's such and such a date in case I'm wrong. I'll prefer to get back to you.
Yeah, we'll get back to that one. So all answers that haven't been answered today, because we're right on 1:30, we'll email through. So I'll send those through to Heidi and she'll get back to you on those. Getting lots of thank yous just coming through as well, which is lovely. Thanks, Vicky. And thanks to the others that have sent the beautiful comments, and I'll forward those to Jacqueline and Heidi as well. Okay, so we're right on time. I'm going to thank everybody for being here today. Thanks for that information. It was really informative and such an important topic with aged care. And thank you to everyone out there for doing such an amazing job in these times. We're all thinking of you and really appreciate it. All right, thanks everybody, and good afternoon.
Everyone.
See you, Jackie. See you, Heidi.
Thank you.
Bye, everybody. Thank you. See ya.
Bye.